We are kind of over time, but we're not going to steal any time for our next speaker. Welcome Tom Walsh, who's all well known to you. But we will say, Tom, you have precisely half an hour. Thank you. And we'll be signaling from down here as well.
I self-signal. Thank you. Good morning. Let's see. It's not showing up here, so I direct it from here. So by way of introduction, we had just completed the AAA Aspergillosis meeting, where we spent 3.5 wonderful days contemplating just pathogenesis, diagnosis, treatment of invasive aspergillosis. The year prior to that, we had a forum on mucormycosis where we spent 3 days in Marathona in Greece reflecting on mucormycosis. In the next half hour, there is no way I could cover the diagnosis, treatment, and prevention of those plus other molds in a manner that would review the entire area. So for this august audience, we're going to assume much of that, and we're going to instead try to tackle the more challenging questions. And those questions are, what can we do to help our patients today, tomorrow, and in the future through intelligent clinical trial design, translational laboratory research, and ultimately bringing to fruition approved innovations. So by way of introduction, we have a wide variety of molds. Aspergillus and Mucorales, Highland molds, epitomized perhaps most strikingly by Fusarium with its devastating consequences. Domatiaceous molds, controversial and taxonomically as to where it belongs. For convenience, we'll include Scedosporium here, but we could fill literally a blackboard with the domatiaceous molds as well. And our focus will be on diagnosis, treatment, and prevention, though largely with an eye toward treatment. We're going to review some of the current approaches initially for Aspergillus, identify some of the unmet needs, focus on individual potential areas of investigation. And by way of aspergillosis, often the mind immediately moves to the acute invasive pulmonary aspergillosis. But we really need to take a broader step and purview to understand, yes, we have acute invasive aspergillosis, yes, with devastating still mortality, still attributable mortality, but there's a wide population of chronic aspergillosis. I was privileged to work for a month back and forth and a week in the clinic with Dr. David Denning, learning at the management of chronic aspergillosis. It is a very different disease. We've now established a tri-state consortium in a small clinic helping to manage these patients which really struggle with a very different pattern of disease and opens itself up for potentially further investigation. ABPA, Dr. Stevens pioneered this concept of steroid-sparing development for itraconazole. Extrapulmonary disease, very distinct diseases unto themselves. We often have agents that are readily approved, and then we don't know what to do in the central nervous system. Mycotic keratitis. We've initiated a systematic study of fusariosis and aspergillosis of the eye. Our ophthalmology colleagues are masters in this disease. We should behoove ourselves to contemplate becoming more involved in this area where there is a crying need for new innovations and new pharmacology. So if we take the first step, what are the strategies for diagnosis of invasive aspergillosis? It starts, first of all, with host recognition that we've heard very nicely from Dr. Wiederhold, clinical manifestations, diagnostic imaging, microbiologic documentation, culture biomarkers, and probably that which comes to mind most readily for where we can make further advances above and beyond the educational realm would be within biomarkers. We have galactomannan, 1,3-beta-glucan, and PCR, in which we've been blessed with some very, very important advances. But there are some limitations in terms of the biomarkers, and one of them is the rapid availability. We've taken numerous polls, and the majority of institutions, both in Europe and in US, and certainly in Latin America, and in many institutions in Asia as well, and Middle East, most institutions do not have in-house staffing or resources to perform galactomannan or 1,3-beta-D-glucan. It is usually outsourced, and that may take anywhere from 3 to 5 days, even longer depending upon the contractual arrangements given the increasing centralization of laboratories. And for PCR, obviously, very important critical advances have been made, but we're limited commercially with available platforms. And even if you have a well-defined methodology for given molecular pathology core laboratories, they will simply tell you they do not have the staff unless there's some very special interest because of all the other demands for given molecular pathology tools that have to be brought online. So one of the approaches is how can we come to the bedside? And I'd just like to introduce the concept of potentially exploiting further the idea of bedside lateral flow technology. This is from recent work from the UK, from the Public Health Department in Cardiff with Dr. White and colleagues, where they've used basically the strategy for a novel system using comparing the lateral flow device with ELISA to that of PCR. Here on the right, you can see, here on the right, you can see identification band, typical for lateral flow for Aspergillus antigen. This is a relatively weak band. This is a negative, and the strong positive there is a control band. So using this technology, they were able very nicely to be able to show relatively high specificity, 98%, as well as relatively high sensitivity, comparable to that of what one might see with conventional PCR, conventional galactomannan, suggesting that while one could always invoke certain limitations, the rapid turnaround time potentially at the bedside or just inside the laboratory could make an enormous difference. And though this is performed on serum, one could readily translate that with the proper matrices to everything from bronchoalveolar lavage to CSF, pleural fluid, joint fluid, otherwise sterile fluids that potentially could have invasive aspergillosis. Further bringing strategies to the bedside, but with much more challenging technology, the work of Dr. Marty and colleagues at the Brigham with Dr. Koo, his junior colleague, his first author, they've employed microbial volatile organic compounds. This is not a new idea. Our colleagues in Australia pioneered an effort with U.S. Department of Agriculture. We've been harnessing their technologies that are used for detection for aflatoxin. But very nicely, they have technology now that can be brought right to the bedside. It's portable technology. And notably, they've detected different MVOCs, microbial volatile organic compounds, including sesquiterpene and geranyl lactones. And with the capabilities of detecting these novel markers, they come in with 94% sensitivity in 34 patients with invasive aspergillosis, a little cart that could be literally wheeled right up to the bedside. Subject to clinical investigation, part of our purview, absolutely. This technology, again, goes very nicely from bench to bedside with a good scientific rationale. Moving to treatment of invasive aspergillosis, I depicted here the molecules well known to you. For primary therapy, strictly by licensing, we have voriconazole, isavuconazole, and or by guidelines, liposomal amphotericin B does have a special role for the groundbreaking ambuloid study, and certainly in health resource-deprived areas, I still see deoxycholate amphotericin B, for example, being used in Latin America. Even voriconazole can be very difficult to come by. Salvage therapy, we still have POSA, CASPO, ABLC. Depending on institutional practices, these obviously may differ. But the question arises, how can we improve our current situation? Yes, we need new antifungal agents. Yes, we need to augment host response. Both are critical. But then if we ask, well, how can we make things better? This, of course, is the pivotal trial from isavuconazole versus voriconazole. And I bring this just to bring us up to date. What is the current state of the art of where we are with clinical trials? Well, this nicely conducted clinical trial took 6 years to to conduct despite massive efforts. 520 patients successfully enrolled, 102 centers from 26 centers, approximately 1.5, or if you will, 3 patients every 2 weeks, literally across the world, and all-cause mortality. Using all-cause mortality as the endpoint, it was comparable, isavuconazole was comparable to and fulfilled non-inferiority criteria to voriconazole, but with overall mortality still 19-20%. If you look at many of these patients carefully, as we've seen with other trials, aspergillosis is still playing a role. Host responses are critical, but the most profoundly compromised hosts are often not responding to our antifungal therapy. So if we then ask the question, what can we do in terms of improving the current state of the science, given what we have here, we can ask the questions, how can duration of study be decreased? Do we really need a half a decade? How can numbers of patients be reduced? Do we need 527? How can the amount of resources be diminished? Do we really need up to $20 million? The solutions can be found perhaps, and we can discuss them here later, in endpoints, adaptive designs, building upon our oncology colleagues, and biomarker surrogates, for example. And if we look at biomarker surrogates, Ellie and I see, and Gail Wood very nicely introduced in 2007, building upon a substantial body of laboratory animal data, that if one looked at galactomannan as an outcome marker, it was significantly different. Persistence across of galactomannan, typically it will just not change, versus a resolution, correlated very strongly with a significant p-value in 56 patients, and this hypothesis is supported from literally 28 laboratory animal studies from our invasive pulmonary aspergillosis model systems, correlated very strongly. But undeterred, in 2008, Dr. McKelly from the same center with Ellie and Gail Woods then studied 257 proven probable patients of invasive aspergillosis. And I won't go into the fine details, I just show you the analytical table of the K coefficient analysis, and showed highly significant correlation with outcome and therapeutic response. And still there was skepticism, well, perhaps we should or should not. Yet we see the robustness of cryptococcal antigen, and we then see the languid period of time it takes to in which to conduct clinical trials in aspergillosis. The theme continues because Dennis Neophytis recently reported out from 56 patients similar observations, a strong correlation between circulating fungal biomarkers and clinical outcome in invasive aspergillosis, both for beta-D-glucan, both for galactomannan and now through beta-D-glucan, also which has strong laboratory animal support. So again, the question arises, can we do better for our patients? Can we do better for the limited resources that we have by finally bringing to clinical trial, now, not next decade, the use of surrogate biomarkers? So how can we further improve therapeutic response? And one is going back to the question of combination therapy. If you look at, and then certainly we have augmentation of host response, but if you look at just the general concept of the impact on the FKS1 target, meaning 1,3-beta-glucan synthase, and ergosterol simultaneous inhibition in vitro, in vivo, multiple laboratory animal studies support this concept. Yes, we have the clinical trial, and as colleagues have told me that all of those outcomes did not happen by chance. If it had been powered 30 to 40 more patients, it would have been highly significant. And so one cannot just simply dismiss an entire biological framework simply on the basis of study design that may have been underpowered in that regard. Here, I'll just take with you the recurring theme that if we look at isavuconazole and microfungin from our experimental aspergillosis, further laying the foundation for potentially future clinical trials, we have significant differences in relationship to the residual fungal burden, to lung weights and pulmonary infarct score, which are markers of pulmonary injury, resulting in significant loss and ultimately in our patients of death. And we also have a significant impact on survival probability with the combination in comparison to the untreated controls. If you look at the biomarkers, Galactomannan, 1,3-beta-D-glucan, once again, you see significant impact. And there's strong correlation between all the outcome variables, Spearman rank correlation coefficient, and the biomarkers. Acute pulmonary aspergillosis are already heavily immunosuppressed, profoundly. Neutropenic, corticosteroids, GVHD, often complicated by CMV, signal transduction inhibitors, anti-TNF-alpha agents, the underlying diseases associated with AML, MDS, stem cell transplant, as well as primary immune deficiencies. But the measures available to impact on those poor patients are limited. We can hope for recovery from neutropenia with GCSF. We and others, and David Stevens as well, have used GM-CSF in individual patients, backed up by our in vitro and vivo data with favorable outcomes, but it purely is not systematically studied. Here, granulocyte transfusions will still work, but are very resource intensive. And then you have immunomodulatory augmentation with a tiny handful of agents, GCSF, GM-CSF, and interferon gamma. That's it. On the other hand, we have other potential molecules, IL-8, IL-12, IL-15, IL-17, IL-23. They do clearly augment monocyte macrophage neutrophils. You can show it against Candida, against Aspergillus. However, we do not have the full understanding of the immunopharmacology of how much to give, to the point that we could elicit autoimmune diseases in our patients, including RA, inflammatory bowel disease, interstitial pneumonitis, and autoimmune hepatitis, psoriasis. Worse yet, we can accelerate GVHD if we don't understand the immunology properly, or activate solid organ transplant allograft rejection. So more targeted therapies are clearly needed, and improved immunological profiling. There's an enormous progress that I will not address here in terms of profiling patients for literally up to 1,200 cytokines and chemokines using proteomic technology that may help to provide a bioinformatic rationale. How could we further augment host response? I refer to it as smarter immune suppression. And that is that it can be, working with our oncology and transplant colleagues, we now have more targeted immune suppression. Certainly, renal transplantation is a classic example. We're not seeing pulmonary aspergillosis to the degree that we used to in renal transplant recipients, and that's because of great advances in immunology. I further have borrowed from the IACUC, the Institutional Animal Care Use Committee, concept of reduction, refinement, and replacement of immunosuppressive molecules from intensely immunosuppressive to more targeted immunosuppression. Let's switch our attention to mucormycosis. These are well known to you, the rapidly growing organism where it's literally a lid lifter to the crushing, debilitating ethmoidal sinusitis and sinoorbital disease that rapidly goes into the brain to cavernous sinus, leading to hemorrhagic infarction and cranial nerve entrapment. And then certainly finally, and this is one of our recent children with devastating mucormycosis of the extremity simply from a scratch on the playground. So why is early diagnosis important? I start with this, and I show that plate intentionally because of the rapid growth of these organisms. Time is not on your side, and to sit and contemplate it in rounds is probably remiss when one considers the rapid way in which we could grow. So the organism can grow. The hypothesis for us would be early intervention may reduce or prevent angioinvasion, direct tissue injury, extension into critical sites, including eye, brain, great vessels, and progression to dissemination. It may also reduce the need for extensive surgical resection and reduce disfiguring surgery, and certainly reduce suffering, especially associated with invasion of sensory nerves. And we hope improve outcome and survival. But is early diagnosis beneficial? If I told you that I had a compound that could improve survival by 100%, we would be doing cartwheels in the aisle. I do not. But we do have data from Dimitris Kontianis to show that early diagnosis doubles survival. So Dr. Camillus and colleagues at MD Anderson very nicely show the impact of effective amphotericin B in 70 consecutive patients, where delayed therapy resulted in a twofold increase in 12-week mortality. Conversely, early diagnosis significantly reduced mortality, improved outcome. and delayed treatment was an independent factor for poor outcome. So how can we improve? Well, we recognize host factors, of course, assessment of clinical manifestations. We can use imaging modalities. We can train our colleagues with expertise in histology, cytology. We can enhance microbiologic methods, and we're seeking to pursue advances in molecular, proteomic, metabolic, and antigenic detection. But there's a kind of Bayesian probability. You cannot typically screen everybody for mucormycosis. There still needs to be the educational role of training physicians and other healthcare providers for early recognition of the individuals at risk. This is just to underscore the role of PCR. This is from our laboratory animal system, first demonstrating the from light cycle PCR technology with primers across 18S going into the early segment of 28S. We're able to detect the key pathogens, including Cunningham-Ella in another assay, very good sensitive ROC curves, and to our delight, and this is from Microbial lavage, to our delight, however, we were able to see plasma amplification. This is likely the result of our efforts in DNA and RNA purification steps. And here you can see the strong signal coming up in plasma. So this technology, these methods have been adapted. And I'm delighted to say that Dr. Million and colleagues in France have, through the French surveillance network, very, very nicely have now shown that one can identify in plasma using quantitative PCR 81% sensitivity. This is extremely encouraging and represents an opportunity potentially for screening of our very high-risk patients or targeting in serum, preferably also bronchoalveolar lavage, patients at risk for invasive mucormycosis. Taking it a step farther, however, and reflecting on what we just said previously, that the molecular systems, even if they're well developed, may not reach their way to every major hospital, university hospital, just because of prioritization and staffing. So in that regard, we're back to the laboratory animal model system. These are three of our animal model systems for rhizomucor, Rhizopus oryzae, Mucor cercinoloides, looking at similar outcome variables, pulmonary infarct score, pulmonary burden, cumulative probability of survival. These are the workhorses, if you will, of our developing new molecular systems, and this is work now that we've done in collaboration with Mira Vista Laboratories and with help and gracious support from the Schuler Foundation. This is one of the little boys who I took care of, who unfortunately, Hank Schuler, who died from his mucormycosis at the age of 17, a very talented athlete and prime member of the community that reminds us every day of the devastating consequences of this terrible pathogen. But we reasoned with Dr. Wheat that why not develop an antigen system that could make an ELISA tray available in every laboratory potentially, where they would not necessarily be able to have PCR. If they did, it could even complement. So here in the bronchoalveolar lavage, we have receiver-operator curve of 77% sensitivity, 93% specificity, a strong correlation with high degree of reproducibility, both in the BAL fluid supernatant as well as BAL fluid pellet. We further evaluated the range and found across all the different several species, oryzae, Microsporus, and Mucor, our highest antigen levels were in the genus Rhizopus, less so in the Mucor. But this is the first step and first system of antigen detection that we're aware of that hopefully would be able to be further developed. How could you further develop this? How do we bring new developments for molecular diagnosis of mucormycosis, a disease that occurs in 1 to 3 million? Well, foundation support, as I illustrated, SBIRs, collaboration with other industrial partners involved in mucormycosis research, the European Confederation for Medical Mycology, with that working group, the Zygomycosis working group, ISHAM working group, and then, of course, MSGERC. Well, what do we have for treatment? The list is smaller. I put deoxycholate, amphotericin B by virtue of historical interest. None of these molecules in and of themselves have have a sole priority. They've been widely used. DMB was widely used. LAMB, liposomal amphotericin B, has taken predominance in many institutions. We have much more data. ABLC has data in salvage. As you know, isavuconazole was recently approved for primary therapy based upon a study we'll discuss very briefly. And posaconazole, of course, has data supporting its salvage role. So we do have a small group of molecules that are capable of impacting on this disease. Are they optimal? No. Do we need more progress? Certainly. So what are the challenges in developing, though, new therapeutics? Small numbers. If you thought Aspergillus was challenging, 1 to 3 per million is going to be even more challenging. Where are the resources to be able to develop them? Well, one possibility may be consortia of industrial partners, government agencies, and mycological societies coming together, collective recognition of the public health needs, patient testimony, which is extraordinarily compelling, and in that regard, a model based upon orphan drug development and extending that model to other mold infections. So within my time constraints, respectively, Dr. Donnelly, we have articulated critical needs for new diagnostic tools in Aspergillosis, Mucormycosis, and other mold infections. And there is an imperative need, not only for therapeutics, but also for new endpoints, and a critical need for strategic partnerships, which I would hasten to add begins here. And thank you very much.